Thank you. It's a pleasure to be here this morning, and I'd like to thank SAGES for the opportunity to be involved with this interesting and somewhat controversial forum, and also thank Dimitri and Ozanen for the invitation here. So I'll be talking about robotic use in the area of bariatric surgery, and I was given the specific task of discussing gastric bypass. These are my disclosures. I don't think any of these are particularly relevant. I will say, and I probably should add to this, I did have many years ago stock options in Computer Motion, which was purchased by Intuitive, as many of you know, but I did divest those about 4 or 5 years ago. Just real quickly, just to remind everybody about Obesity Week coming up. I have the distinct pleasure to be chair of Obesity Week, and we'll be in New Orleans in 2016, November. So mark your calendars if you want to be updated on the latest advances in the science and practice of obesity. And finally, for some of you who are also interested in advancing their skills and knowledge in MIS surgery, minimally invasive surgery symposium next year will be in February 2017 in Vegas at the Encore.
Shameless plug, but a great program, and I was on it.
Shameless self-promotion, I'm sorry. Okay, so I'm going to talk about robotics, and I do want to acknowledge my colleague and former partner, Tom Rogala, who's now at Case Western. Tom has done a nice review of this literature, so I have pilfered some of his slides with his permission. So I do want to acknowledge. And also, about 4 or 5 years ago in our group, we decided to really evaluate how the robot would fit in bariatrics. So I assigned Tom to that task over a period of about 3 or 4 years. He gained a lot of experience in robotics, and we have a paper coming up, soon to be hopefully published, comparing the robot bariatric procedures with our standard laparoscopic procedures within our own practice. So stay tuned on that. So at the Cleveland Clinic, we have quite a few robots. This is just one of a couple that we have in a research lab. I think we have 7 clinical robots, so we have as many as anybody in the country, used primarily by the urologist and the gynecologist. General surgeons have had access to the robot for quite a while, and frankly, there just has not been a whole lot of major penetration within general surgery proper, although everything's been tried at the clinic. My own experience goes back to the, 96, 97 in Pittsburgh when we had Zeus, purchased a Zeus, and spent a lot of time trying to figure out how to use it, and didn't seem to, at least at that time, that technology, be able to fit it into clinical practice. Now, there are some significant potential advantages of the robot in bariatric surgery and gastric bypass. I think first and foremost, on any new technology, hopefully we can see a benefit in the patient. And so, and as the president of Intuitive has pointed out, in his own words, he felt that the major advantage of robotics was increasing access to minimally invasive surgery for patients. And I agree that's true, and that's probably why it has somewhat been successful in urology. Laparoscopic prostatectomy, for example, prior to the robot had a penetration of about 5%. And with the robot, quite a larger number of patients can get access to minimally invasive surgery and the associated benefits in terms of reducing perioperative morbidity. However, in certain fields like bariatrics, so we are already 98 penetrated in MIS. The only time we do an open duodenal switch, gastric bypass, is when it's a revisional case or there's a complication, okay? In fact, bariatrics is the most. We're more penetrated in MIS than cholecystectomy. National records show for cholecystectomy it's about 85 to 90%. So it's hard to really show or demonstrate that the robot is going to convert an open gastric bypass to a laparoscopic. The second thing is, could it help the surgeon do a better job? For example, anastomotic leaks. That's one of the biggest complications, potentially lethal. Fortunately, it's pretty rare. Leak rates are about 1 to 2%. So can the robot drop that even further? If it can, that's a huge advance. And can it also perhaps reduce complications in high-risk patients, revisional cases, very high BMI, thick abdominal wall, very difficult cases? That's another potential area. Could it reduce costs? Well, most of the studies, and I'll show you in a minute, show the opposite. Perhaps it could reduce costs if it could reduce complications. If you can reduce the leak rate, then you can reduce the overall cost of surgery, or maybe reduce OR time. So far, that's not been shown to be the case. And then finally, the other area of advantage is it could improve the surgeon's situation. Better ergonomics, less injury problems, back issues, and so forth. So that's another potential area that has been discussed and perhaps reviewed, but not necessarily been proven. Within general surgery, again, there has not been that much penetration, and maybe it'd be helpful for the audience. How many surgeons are using a robot regularly in their practice? Okay, see about maybe 10 hands up, so maybe a tenth of the audience has used it. Well, for those who are using it in general surgery, this is sort of the distribution. It's fairly equal distribution between foregut, colorectal, bariatric, and others. There's some areas of more recent interest. I think hernia is beginning to catch some interest. Colorectal seems to be maybe the most, particularly in more distal or rectal type surgery. And there has been an increase within bariatrics, the number of surgeons who have at least tried it. Goes up to the fourth quarter of 2014, so a little more than 200 surgeons have at least tried it. Now, there's about a little more than 2,000 bariatric surgeons in the U.S., so maybe 1/10 have actually tried it. This doesn't show the adoption rate, but this is the number of surgeons who've tried it. Remember, the robot has been around for about 15 years, so that should tell you something as well. Now, within bariatric surgery, these 4 common procedures, just giving you a summary of the procedures, technical difficulty, operative time, operative risk, effect of the operation, long-term risks, and so forth, where the robot could help the surgeon. It'd be hard to imagine a fairly quick, easy, short case, the robot would really be able to make a big difference. So maybe it's in these more difficult procedures that bypass duodenal switch where you might see potential benefit. History of robotics. Santiago Horgan did the first gastric band. I don't know if Santi's going to be able to make it. He's supposed to speak after me.
He's not feeling well, and we're still waiting.
Okay. Okay, and I think Santi also did the first gastric bypass, and the first robotic sleeve was done in 2007, and then Ranjan Sedan did the first BPD in 2000. So over 15 years ago, it should tell you something. 15 years ago, the first case is done, and not much penetration. Now this is a very nice comprehensive review of what has been published. These are most of the studies. Looking at the various approaches. Some of these are just single series without any comparators. Robotic assisted compared to laparoscopic are some of these. Most of these are relatively modest in size in terms of number of patients, although some of these have several hundred patients, 300, 400 patients. With body mass index fairly typical of a bariatric practice in the mid-40s BMI. The mean operative time is quite variable, but if you look at most of these, around the 3-hour range, up to 4 hours, one was nearly 5 hours. Some of these as low as 2 hours, but most of them are right around 3 hours, so that's a bit longer than the standard laparoscopic bariatric or gastric bypass procedure, which tends to be around 2 hours, 180 minutes. Conversions, that is conversions to either from robotic to laparoscopic, relatively uncommon. And then as one metric of a complication, the gastrojejuno anastomotic leak. You can see here, some of these have 0, but those are relatively small studies. 1%, less than 3%, 1.9, 1.7, 1.0, 2.2. That's about what we see with a standard laparoscopic approach. If you look at a variety of studies, that's about where the averages are, 1 to 2% leak rates overall. So be hard pressed to be able to say that this is a significant improvement in the leak rate. And this meta-analysis, published in Surgical Endoscopy, looked at a variety of number of case studies where there were comparators between the robotic and laparoscopic, about 7 or 8 papers. And you see the forest plots here of 2 very important indicators. On the left is complication rates overall. And you can see that only one of these studies, 1 out of 7 or so, shows a potential benefit and is just barely beyond that midpoint of favorability toward the robotic. All the others are really right down the line, showing essentially no difference in complication rates between the procedures. On the other hand, the operative time is pretty much skewed the other direction. Most of the studies show that the robot increases the operating time compared to a standard laparoscopic procedure. And this, of course, includes learning curves and docking time and instrument exchange time and all that which is sort of built in part of the procedure time. Here's a study looking at risk factors for complications after robotic surgery, and this sub-theme of this session is supposed to be complications. And as you look down, no different than laparoscopy. Obviously, higher risk patients, ASA 3 or greater, are going to have higher odds ratio of complications, prior bariatric surgery. They have major morbidity prior to surgery or comorbidity, like history of previous surgery or someone who's having concomitant procedures like band removal and conversion to another operation are going to have a higher risk of complications. Now, there are some specific complications of the robot, and you're not going to necessarily see those in these type of literature reports. You have to go to internet and look at the MODS database, as Ozan had done. These are pretty rare. These are equipment failures, things like that. You're really going to see those in a literature review, so I won't be able to really comment too much about that. Here's an interesting study that looked at cost. This is sort of a hypothetical economic analysis model looking at one outcome, leak rates, and showing the different procedures. Red is just open gastric bypass, blue is laparoscopic, and green is robotic. And if you focus on the blue, it does sort of make sense that if you can decrease your leak rate, and this is hypothetical again, from 4% down to 1 or 0, the overall cost of the procedure among hundreds of patients, of course, is going to decrease. And I'm not sure why this economic model you don't see the same drop for open or the robotic. But I think the point is that if any technology can reduce a major complication rate significantly, then it can overall reduce the operative costs. And even these rare complications, like a leak, although it's quite rare, if the patient ends up in the ICU for a few weeks, that can quintuple the costs quite quickly. Some organizations have looked at this in sort of a consensus process. The EAES, which is the European Association for Minimally Invasive Surgery, sister organization of SAGES, did review the literature on the subject and came out with a consensus statement. And it's pretty much in agreement with my own opinion on this, and it has why robotic surgery has theoretical and technical advantages. There seems to be, at this point, no significant translation in terms of improving actual patient outcomes at this time. So hard to actually justify use of the procedures at this time within general surgery. So as I get to my conclusion, in question I was asked to address, is the robot better for bypass? And based on the literature, the evidence available today, not yet, not there yet. Now there is promise, and nobody's a greater enthusiast for technology than me. I think there's opportunities, and perhaps there's a few generations of technology advancement necessary to really get to the point where these robots actually make us better surgeons, reduce the intraoperative, reduce complication rates, or make us faster. If these robots can make us faster, and I personally think that's going to be the biggest advantage. If they can make us do the operation in half the time with the same outcomes as the standard laparoscopic, then it's going to cut costs dramatically. And a hospital can do more cases in one OR, and you overall will save money over time. And I'll just close by showing that, again, I'm an enthusiast for technology. I got a chance to sit on one of these new robots. I think there's about 4 or 5 robots in the showroom. It is cool technology. It is really fun to do this stuff. But at the end of the day, the ultimate goal should be to improve patient outcome, and at least within bariatrics, not there yet. Thank you.
Thank you. Thank you very much, Dr. Schauer.